Hello, everyone, and thank you very much for the invitation. Today, my talk will be about the neuroanatomy of consciousness. But before that, I would like to inform you about the second World Coma Day that will be held online on March 22nd next year. And it's going to be a 24-hour event, and you are all welcome to attend. So today, I would like first to describe what we mean by consciousness, how we assess it at the bedside, what can brain imaging tell us about consciousness, and then briefly the perspective and what's next. So what do we mean by consciousness? So we can actually define consciousness in two main components, wakefulness and awareness. So wakefulness is the eyes opening, and awareness is the subjective experience that anyone can have. And when we look at those two components, usually they are correlated. So you and me now, we should be all awake and aware. And then tonight, when we will go to sleep, those two components will decrease. Except when we're gonna have vivid dreams during rapid eye movement sleep. Here you see that we can be a bit more aware than we are awake. And even more so when we have lucid dreams. So when in the dreams, we become conscious that we are dreaming. The two states that have a low wakefulness and a low awareness are coma and general anesthesia. And then we can see that we can also have clear dissociation between those two components, especially for patients who are in a vegetative state or unresponsive wakefulness syndrome, where they only show eyes opening, and so that they are awake, and yet they have no signs of consciousness, they are not aware. We have the same dissociation in some kind of epilepsy and also in sleepwalking. And then we have patients who are in a minimally conscious state who will recover some sign of consciousness, and yet so they will be both aware and awake. And then the last entity, clinical entity that we sometimes observe is the locked-in syndrome. So this is patients who are recovering from a coma and they are awake and aware, but yet they cannot show us because they have quadriparesis or quadriplegia that prevent any motor responses. So this was for the two components, arousal and awareness. And so we can see that arousal is mostly mediated by brainstem structure here in yellow, whereas awareness is mostly mediated by the cortical areas, and more specifically, the frontoparietal network. And then this awareness can itself be divided in two components, awareness of the environment and awareness of the self. So awareness of the self is everything that's related to the self. So it's the mind wandering, it's the inner thought that you can have in your mind, in your brain. And this is usually mediated by internal area in the cortex, as you can see here in blue. And awareness of the environment, it's everything that's related to your sense. So that can be when you hear something, when you see something, when you smell, when you taste, and this is all mediated by external area of your cortex, as you can see here in red. And usually those two, the network, internal and external network, are anti-correlated. And so spontaneously we switch every 20-30 seconds between those two networks. So how do we assess consciousness at the bedside? So there are actually three things that we are looking at when we see patients in the intensive care, but also in neurology and rehabilitation center and even nursing home sometimes. The first thing is arousal. Can the patient open the eyes, yes or no? And that differentiates between the coma and the unresponsive wakefulness syndrome. Once we know that the patient is aroused, then we will look for signs of consciousness or awareness. And that will differentiate between an unresponsive patient and a minimally conscious patient. And when we know that the patient is minimally conscious, then we will look for signs of communication. So that can be binary communication. For instance, close your eyes to say no and squeeze your hand to say yes. And once we have a functional communication, then we say that the patient has emerged from the minimally conscious states. So the most prevalent sign, the most observed signs of consciousness that we see in patients, using here the coma recovery scale revised, there are actually 5 of them that can denote 99% of the minimally conscious states. The first behavior is reproducible movement to command. So that can be look up for yes, squeeze the hand, move your head. Then we have visual fixation, visual pursuit, localization to noxious stimulation, and then automatic motor responses. And that can be, for instance, scratching the nose, touching the tracheotomy, grabbing the sheets. That's all behaviors that are automatic motor responses. But then recent work has also shown that maybe some other signs of consciousness could be taken as a sign of minimally conscious states. So for instance, the resistance to eye opening. So manual eye opening, and we see some patient like forcing to close. So maybe that could also be considered as a sign of consciousness. Or oral feeding, if they have an efficient oral phase of swallowing, maybe they should be considered as conscious. Same for sounds localization. Recent evidence are showing that this could also be considered as a sign of consciousness. Same for auditive habituation and for some responses after olfactive stimulation. But as we will see, responsiveness or motor behavior is not always necessarily correlated to consciousness. And here we have 2 cases, 2 patients who came at the University Hospital of Liège, and both were diagnosed as vegetative states or unresponsive wakefulness syndrome, and they show no signs of consciousness at all. And yet you'll see here that they both have very different brain activities underlying. So for here we have a patient who had brain metabolism, and you see that everything is in blue. So there's a lot of hypometabolism, and it's really global. When we look at the resting state fMRI with the default mode network, we see that there's no brain activation. We look at the white matter tract, and we see that it's severely damaged. And then we also ask the patient to do imagery tasks, so imagine playing tennis and imagine moving into a house. And we see that there is no activation when we were asking to perform such tasks. So in this case, we can confirm the behavioral diagnosis of unresponsive. But on this other patient, who was also completely unresponsive at the bedside, no signs of consciousness, and yet you see a very different brain patterns with preservation, relative preservation of the brain metabolism, with brain area in red here and green. We see a partial preservation of the default mode network. We see the white matter tract that are relatively preserved, and most importantly in this case, we also see that there are brain responses that are reproducible when we were asking the patient to perform some task. So in this case, clearly the patient was not in an unresponsive wakefulness syndrome, but what we call now a minimally conscious state star or cognitive motor dissociation. So it's important, the first thing is consciousness is not the same as behavioral responsiveness. That's why we are using a lot of different imaging techniques. And here we will have other talks later today that will explain a bit more all those neuroimaging. But as a summary, what we can say is that most often consciousness cannot be described just by the structure. So here we will use mostly MRI to look at the etiology. So that can inform on the etiology. Here we see that there is a trauma, whereas here we see that it's more like an anoxia with abnormalities in the subcortical area. And then it can also inform us on the chronicity of the brain injury. For instance, here for the chronic states, we can see that there is some atrophy in the brain. But recently, using more advanced technologies, it has been shown, and this is the work from Yitka Anand from our team, that you can actually correlate consciousness with the structure of the brain. And here, more specifically, there are some brain areas in the gray matter, but also in the white matter that are important and that can allow to classify between minimally conscious and unresponsive patients, both at the cortical and at the subcortical level. Then previous studies, notably mostly with Professor Stephen Lohays, using PET scan and brain metabolism, show that consciousness is not a global brain function. And here we see, so with the brain metabolism, like you and me right now, we should be at 100%. Patients who are brain dead, they are at 0. We see the black box here. Tonight, when you go to sleep, you will have a reduction of about half of the global metabolism. When you start dreaming, you will have an increase of the brain metabolism. If you undergo general anesthesia, again, you see a massive decrease. If you have a good anesthesiologist, and I hope so, then you have a full recovery up to 100%. And then we see here patients who are in an unresponsive state, they also have a massive decrease of brain metabolism. And importantly, we see that some of them, they recover, and yet they don't recover full global metabolism. So that's why initially we said consciousness is not a global brain function, but again, recently with more advanced technology, we were able to develop some index, and here it's the metabolic index that look at the brain metabolism, and that allows to differentiate between unresponsive and minimally conscious with a threshold here of 42, for instance. We also have learned that consciousness is not related to the activation of primary cortices. And this is a study where patients had received noxious electrical stimulation on the wrist. And if we do that in a healthy control, we see that it activates the pain matrix. In patients who are brain dead, there's no such activation. And in patients who are in an unresponsive state, we see that there is some activation of the primary cortices, but these are disconnected from the other area of the brain. And that is not sufficient to perceive the stimulation consciously. However, we see that patients who are in a minimally conscious state, they will activate associative area on top of the primary cortices. And this is believed to be important to perceive the stimulation. So there's lots of evidence from our group, but also other groups, that consciousness is more related to the frontoparietal network. And this is the work with PET scan, again, with brain image, with brain metabolism, where we see that patients who are in an unresponsive state will have a global diminution of the brain metabolism, both at the front and the back of the brain. Whereas patients in a minimally conscious state will show some relatively preservation in the frontoparietal network bilaterally. Then on top of having this frontoparietal network that is important for consciousness, it's also very important that there are the thalamocortical loop that are preserved. And this is an old study that actually showed that in a patient who were in an unresponsive state, and we saw that when he recovered consciousness, he also recovered the connection between the frontal area and the thalamus. Similarly, the work of Nico Schiff and colleague has shown that by stimulating the thalamus with deep brain stimulation, allowed the patient to show more behaviors, more conscious behavior. So again, this is evidence of the importance of the thalamocortical loop in the brain for consciousness recovery. Moreover, in recent years, we have also been looking more at resting state, either with fMRI or EEG. And you can see here that looking at resting state fMRI, there are different resting states in the brain. The default mode network, the frontoparietal network, salience network, auditory network, sensory motor, and visual network. And all those networks are also correlated to the level of consciousness, where you see here that in a healthy, in a normal states, you have some different brain activation depending on the network, and then it decreases when you look at minimally conscious states, unresponsive states, and almost no activation in a coma. And this is the same when we look at the resting state EEG, and here more specifically the alpha band, looking at graph theory metrics. And then in collaboration with the University of Milan and the lab of Marcello Massimini, we looked at the complexity in the brain, and more specifically using TMS EEG, so transcranial magnetic stimulation combined with electroencephalography, where you stimulate the brain, you look at the electrical responses, and then you compress this information, and that gives you an index, the perturbational complexity index, that allows to differentiate between a conscious and an unconscious patient or subject. And so here more specifically, if you do that in patients who are in a minimally conscious state plus or minus, so they show sign of consciousness at the bedside, you see that almost all of them will show a high PCI, except those two patients. And then when you look at patients who are unresponsive at the bedside, you see there are actually three kinds of responses. The first response is no response. It's flat. And so this is usually patients who had an anoxia. And then we have patients who show a low complexity. And so this is a simple wave responses that is stereotyped. And this is what we see in patients who are sleeping without dreams. And that's the most common response in unresponsive patients. But we also see that some patients have a high complexity, a high PCI, as you can see here in purple. And those are believed to either they may recover better than the other patients, or they are already in a state that allows consciousness, but yet we cannot see it at the bedside. So consciousness is related to the complexity of the brain. Then we also have shown that there are different connections in the brain, and the top-down connections are also important for consciousness. And here we can see using auditory stimulation and high-density electroencephalography that patients who are in an unresponsive state, they lack this feedback connection from the frontal to the temporal area. Whereas in patients in minimally conscious states, they do have these connections that allows for consciously perceiving the auditory stimulation. And then one more thing is that consciousness is a dynamic process. So all the previous studies that I've shown you, it's basically an average of, let's say, 15 minutes recording. So here, again, these recent years, there have been more and more work looking at the temporal evolution while we do the recording. And we can see that there's actually a difference between the dynamic processes and the level of consciousness. So in conclusion, what we can see from all the studies that have been performed so far is that consciousness is different from behavioral responsiveness. It's not a global brain function, and it does not include necessarily the primary cortices, but we can define it as an emergent property of collective critical network dynamics that involves the frontoparietal network, but also thalamocortical loops, including connectivity and complexity. So what's next? What are the next perspectives? First of all, I think it's important that we try to use as much as we can multimodal assessment when we have to assess patients, and especially to diagnose the level of consciousness. And here it's a recent study by our group that shows that using multimodal assessment, you can have a diagnostic error up to 67%. So I highly recommend to use multimodal assessment if you can. And just to better understand the mechanism of consciousness, this is a nice summary work from Lupi and colleagues. And they propose 5 steps. The first one is to establish a framework of consciousness. The second one is to link brain structure and function, and then to unite macro and micro scale, to combine theory and data-driven approach, and then to integrate the level of description, the imaging modalities, and the theories together. And only then we will really better understand the mechanism of consciousness and consciousness recovery. And then another alternative or things that we can do in parallel is to also study other states of consciousness. As you saw here, it was mostly related to coma and disorders of consciousness after coma, but looking at hypnosis, trance, meditation, sleep, anesthesia, or virtual reality can also help us to better understand consciousness. So I thank you very much for your attention, and I wish you a lovely day.